Buenos días, señoras y señores. Le agradezco mucho al comité organizador por la invitación a participar en este videocongreso. Disculpe, pero mi vocabulario español está demasiado rudimentario y, si me le permite, voy a continuar en inglés. So, my today topic will be the lessons I learned from the LAC trial. These are the results of some old retrospective series who quite all demonstrated better immediate outcomes with laparoscopy, but with very few information regarding the survival, and the randomized trial was eagerly awaited to clarify this aspect. However, a first randomized trial comparing abdominal to laparoscopically assisted radical vaginal hysterectomy was published in 2010. Of course, the number of patients in each arm was very small, but this trial already warned us about the risk of inferior radicality when using laparoscopy compared to laparotomy. These are some important papers describing the technical aspects of laparoscopic radical hysterectomy or laparoscopic radical vaginal hysterectomy. In 2008, people thought they were experienced enough to start such an international comparative randomized study between laparotomy and laparoscopy. The criteria to be accredited need to master both approaches with an experience of at least 10 robotic or laparoscopic radical hysterectomy and sending 2 unedited videos to an American board to control the validity of the technique. And now these are the results of the LAC trial. Every one of you knows perfectly. And as you know, this trial had to be stopped in 2017 due to an imbalance between the two arms, with much more deaths in the laparoscopy arm. And this was the beginning of the end of laparoscopic or robotic radical hysterectomy. Of course, numerous critics were raised against the results of this trial, and they are summarized in this slide and commented by others. I won't develop this aspect. Simultaneously to the LAC trial was published the results of the US database comparing the results of radical hysterectomy before and since the introduction of minimally invasive surgery. And of course, results were very poor, have been very poor since the beginning of the use of minimally invasive surgery. What is strange is that this effect started in 2007 when the surgeons were accredited to participate into the LAC trial. Weirdly, since LAC publication, other papers have confirmed a nil or a detrimental effect of laparoscopy on survival in early cervix carcinomas. To finish, recently the results of quality of life after radical hysterectomy in the LAC trial were reported. They did not show any advantage of MIS over laparotomy. But it's well known that MIS improve only the early quality of life scores, difference which shades off with time, as mentioned already by Combly in the with the LAB2 trial for endometrial cancer. At distance, difference of body image or incisional complications should be probably explored. Thus, it became urgent to modify all the guidelines worldwide. And the ESGO and its president prompted new European guidelines in which laparotomy approach became again the standard approach to perform a radical hysterectomy in early cervix cancer. Things are even clearer in USA, as there is absolutely no place for MIS in the management of radical hysterectomy in early cervix carcinomas. However, randomized controlled trial in surgery are subject to inherent methodological difficulties. Indeed, randomization is a way to avoid bias in recruiting patients, but does nothing to compensate for the differences in surgical proficiency between 2 or even 3 techniques in this example, nor in the misuse of the tool, especially regarding the oncological safety. One can wonder why the results of the LAP2 trial in endometrial cancer are different from the LAC trial for cervix cancer, as no special technical guideline was imposed regarding the tumor protection. It's because the tumor is not at the same level. In endometrial carcinoma, the tumor is enclosed into a uterine cavity, protected by some amount of myometrium and by the cervix, while in cervix carcinoma, the tumor is exposed in the vaginal cavity without external protection. Concerning the laparotomy arm of the LAC trial, the results are really exceptional, much better than observed in previous trials, possibly because of the respect of the protecting maneuvers already stressed by Ernst Wertheim in 1912. But concerning the laparoscopy arm, there was no specific oncological precaution in the trial. And some surgeons probably used a uterine manipulator, which is responsible of tumor traumatism during the insertion with the risk of spillage when opening the vagina. Secondly, the tumor exposure to the pelvis is possible, as observed in this video. And all of us know that this risk is the first reason of a local recurrence, whatever the initial tumor type. So what are the possibilities to prevent the spillage or pelvic contamination during a laparoscopic dissection? A first solution could be to perform a conization to remove the bulk of the tumor, or at least the exophytic part of the tumor. Another one, more elegant, is vaginal preparation that enables the surgeon to isolate the tumor from the operative field and makes easier the separation from the bladder base and the rectum, as you can see in these 2 videos. So this combination of vaginal preparation and laparoscopic dissection was called the Celio-Shao time, or vaginally assisted laparoscopic radical hysterectomy, that we described in 2007 and was adopted by others. But another solution is to perform the same preventive measure, but at the end of the laparoscopic procedure, as demonstrated in this third video clip. The efficiency of this measure can be illustrated by the first report by Christard Köhler, who performed regularly this vaginal preparation prior to laparoscopic dissection. And he presented his experience with more than 300 patients over a period of between 1994 to 2018. And with quite 100 months of follow-up. The results of this experience are very clear, as the 10-year survival rates of this procedure is equivalent to the results at the 3-year survival rate in the laparotomy arm of the LAC trial. So the combination of a vaginal preparation and closure of the cervix prior to perform the laparoscopic steps prevents the risk of death from a recurrence, a local recurrence. After publication of the results of the LAC trial, the European surgeon reported the retrospective experience of laparoscopy in the management of radical hysterectomy. 136 institutions from 29 countries accrue 693 patients operated between 2013 to 2014. So the average follow-up is 4 to 5 years. Although retrospective and multi-institutional, this trial confirms the results of the LAC trial. That is, for tumor less than 2 centimeters, open approach is equivalent to minimally invasive approach, but for tumor more than 2 centimeters, minimally invasive approach has much worse results than the open approach. Interestingly, when considering the technical aspect, it clearly demonstrates, whatever the tumor size, that the use of any kind of manipulator worsens the survival and increases the risk of relapse by 2.76 times. And now, when considering the combined use of no manipulator and protective maneuvers, that means preoperative vaginal closure, the results of these combinations make survival equivalent to open surgery. So the conclusion of this study, this survey, is that minimally invasive surgery in cervical cancer increases the risk of relapse and death compared to open surgery. But avoiding the uterine manipulator and using maneuvers to avoid tumor spread at the time of colpotomy in minimally invasive surgery arm was associated with similar outcomes to open surgery, and further prospective study has thus warranted. Indeed, one single randomized controlled trial do not always tell the truth. And we observe that in different situations where a primary negative trial became a positive one. And that's why, for instance, for ovarian cancer, even when 2 randomized trials tell that primary debulking is equivalent to interval debulking, a 3rd trial has been created trying to overcome the flaws related to surgical experiences, especially. And these results are, of course, eagerly awaited. Concerning cervix cancer, 2 trials have been initiated. The former one in Sweden, the RAC trial for robot-assisted approach to cervical cancer. The advantage of this trial is that the manipulator is banned, and there is a quality control of the surgeon. Unfortunately, this trial is limited to robotic surgery, and the protective maneuvers, such as vaginal closure, are not systematic. A 2nd trial is to be initiated in China with a high number of patients. There is an important quality control of surgeon with a wide experience of 100 cases of radical hysterectomy, but it's not defined if this the proportion of abdominal and or laparoscopic approach. And above all, there is absolutely no recommendation regarding the use of manipulator or vaginal closure. Finally, one can say that with the LAC trial, the laparoscopic or a robotic approach has been buried, and the laparotomy is now the standard of approach. In spite of the fact that I'm a general surgeon, especially involved in laparoscopy, I must admit that the LAC trial is a breakthrough in the management of early cervix tumor. But above all, it stressed the importance of following the rules of any gynecologic surgery. LAC is not the end of MIS, but it should be the end of the misuse of MIS. And other trials are necessary to confirm or not with strict quality criteria of staging, techniques, and oncological management. What do we do waiting for this result, probably more than 10 years from now? For a small tumor, MIS seems safe, but it's important to provide the oncological precaution. Otherwise, the result will be similar but delayed because the tumor is smaller. Or you should enter this patient into a new trial as well for the 1B2. For 1B2, the situation is clearer. Abdominal radical hysterectomy should be the standard. In France, maybe we discussed brachytherapy followed by MIS, but the same, we should compare our results with the previous one as in the Melamed series. For 1B3, at least in Europe, it's clear that definitive chemoradiation therapy is the rule, but neoadjuvant chemotherapy followed by abdominal radical hysterectomy is alternative when radiation therapy cannot be provided. But probably for the future, it's important to spend money as well to dispense the anti-HPV vaccination all over the world to make this disease disappear from us and close such endless discussions. I hope I have been clear enough, and whatever, I thank you very much for your attention.